Dr. Gottheiner is a nephrologist. He is currently the clinical associate professor at Stanford University. He's a neurologist at Palo Medical Center. He's a medical director at Satellite and Wellbound Dialysis Centers, and he's advisor to the Bay Area Association of Kidney Patients. He graduated from Cape Town, South Africa, and he's studied in London and in California and other states. So at this time, I'd like to welcome Dr. Gottheiner.
Thank you, Phil. It was a beautiful presentation, and it gives me great pleasure to see how this organization has grown over the years, and it's a really wonderful group of people who do great work. Thank you very much for what you do. So I have quite a few things to say today, so I think we'll get started. I'm going to talk to you about chronic kidney disease and how we can have you be more knowledgeable, more empowered, and to know, I think, questions to ask. And I'll bring up some new guidelines that have recently been put forward by various organizations and help you along the way. So the introduction will be talking about people at risk for chronic kidney disease. We'll talk about how we diagnose kidney disease and spend a little bit of time on the blood tests that we do, the creatinine, and talk about the various nuances of the creatinine level and the GFR, which I will explain to you. I think it's very important that the biochemical and other abnormalities, I don't really expect you to become experts in the field, but to become more knowledgeable about what these numbers actually mean. So we'll talk about the various stages of chronic kidney disease, and then we'll talk about the various complications of kidney disease. And I will bring to your attention some of the newer guidelines as to some of the aspects of treating chronic kidney disease. We'll then move on to something about preparation for dialysis and transplantation, talk a little bit about stage 5 kidney disease, which is the most advanced level, and then we'll conclude. Now, chronic kidney disease is a very common condition. Approximately 17% of the US population have one or other form of chronic kidney disease, and that would translate to about 25 million people. So it's a huge number of patients who have this condition. The good news is that only a small percentage progress to end-stage renal disease where one needs dialysis or transplantation. And today we have about 400,000 patients on dialysis, combined peritoneal and hemodialysis. We know that early detection can slow down the progression of chronic kidney disease by various treatment regimens that we may start. It's also known that a lot of patients do not have screening tests for kidney disease. So the patients who are at highest risk for kidney disease often pass by this. Fortunately, this number, 25% of diabetics and hypertensives, which is the commonest cause of kidney disease, that number is improving. So we are becoming better at identifying people at increased risk of kidney disease. However, we still see patients presenting very late in the course of their disease, so that it's not all that unusual to see a patient arriving in the emergency room just about ready to start dialysis without ever having seen a kidney doctor. And many of these patients have not been optimally treated with preparation, access planning, anemia management, and so on. Let's talk a little bit about the kidney. First of all, most of us are born with 2 kidneys. You may be interested to hear that as the fetus is developing, the kidneys actually start off in the pelvis as 3 separate little structures that fuse together. And during the course of the development of the fetus, these structures fuse and move up the abdomen, rotate around, and join up at the and come to live at their usual place, which is in both flanks. There are some abnormalities in this migration where you can have a kidney still left in the pelvis. So the main job of the kidneys is to filter and eliminate water, salts, acid, and waste products. That's the main function of the kidney, but it's not the only function. The kidney also produces chemicals which are called hormones, and a hormone is a chemical that travels from one part of the body to another to deliver a message. And examples would be EPO, erythropoietin, EPO, which goes from the kidney to the bone marrow and tells the bone marrow to make red blood cells. So we know, for example, that patients with chronic kidney disease tend to be more likely to have anemia. Secondly, vitamin D. The kidney is the final place where vitamin D is activated and has its effect on muscle and bone and calcium metabolism. The other important thing to know is that the vast majority of the fluid and the chemicals that the kidney filters is reabsorbed before it reaches the final urine, as it were. If that didn't happen, you would be dehydrated and a prune within 6 hours. And then, of course, it has a very important role in blood pressure control. How do we measure the kidney function? Well, I would hope that most of you are familiar with the term creatinine. Creatinine is a chemical, and it is actually derived from the muscle in your body. And the reason why we use this, it's actually derived from creatine, which gets converted to creatinine, and then that is filtered through the kidney and excreted. So that's why it's used to measure the filtering function of the kidney, because it's the only organ that eliminates creatinine for practical purposes. And if you look at your blood test, you'll also see this result on the lab result. It's called the eGFR, which means the estimated glomerular filtration rate. The glomerulus is the tiny little filter. There are 2 million of them in the 2 kidneys. So this creatinine is used to generate, by a formula, this estimated filtration rate. And I'll go through the different levels of the filtration rate in a little while. Now, sometimes it's a little difficult to interpret these results, so we have a finer tuned test, which some of you may have had, and that is a creatinine clearance. So this measurement tells you how much of your blood is cleared of creatinine per minute. But the cumbersome thing about this test is that you need a very accurate 24-hour urine collection. How many of you have had a creatinine clearance measured? There we go, quite a few. So it is a bit cumbersome, and you have to collect every single drop, and it has to be perfectly timed, but it does give you a little better information in certain circumstances, and I'll give you an example of how this can be important. We also use the urinalysis to help us try and decide what kind of kidney disease we're dealing with, and we look at various components of the urine, like the sugar and the protein and blood, and look at it under the microscope. And then we also have additional blood tests that help us in looking for the diagnosis. An example would be, if it's a diabetic, you would see abnormal blood sugars or A1Cs. A patient with lupus will have various abnormalities in the serologies for lupus. We also have imaging tests, like ultrasound being the commonest image to see what the structure of the kidneys look like, but there are others as well. And then finally, we sometimes revert to a kidney biopsy to see what the cells look like under the microscope. Kidney biopsy. So, what is the definition of chronic kidney disease? Well, these are the officially recognized definitions. basically any kind of kidney damage that persists for more than 3 months, or an eGFR of less than 60 ml per minute adjusted for surface area that persists for more than 3 months, or persistence of protein or albumin in the urine that's present for more than 3 months. But that would be actually come into the first component there. Any sign of kidney damage, whether it's an elevated creatinine level, an abnormal urinalysis, and so on. What are the commonest causes of chronic kidney disease? Well, here the 2 commonest causes would be diabetes and high blood pressure. In New Zealand, for example, diabetes accounts for 50% of all patients with end-stage renal disease. Together with hypertension, it's about 65% in this country. Then we have different forms of glomerulonephritis, which is a condition where protein leaks out through the kidney, into the urine, and is due to some structural abnormality of the little filter, the glomerulus, hence the name glomerulonephritis. Polycystic kidney disease is another fairly common condition. Obstruction to the kidney, and then all the others, and then many others, genetic causes and so on. So when we get the, and I don't want to spend too much time on this, but this is the the ways we do the estimation of the filtration rate. Are you all familiar with the term GFR? Is this something that, so, the first formula, the first equation that was around was the so-called Cockcroft-Gault formula, which estimates the creatinine clearance instead of doing a 24-hour urine collection. This is actually quite a reliable test. And the variables would include the age, the weight, the sex, and the creatinine. And that used to give us a fairly good estimation of the creatinine clearance and would save us quite a lot of trouble. It's a little less accurate in the very young and the very old, and obese patients, amputees, transplants, but the normal value was 80 to 120 ml per minute. Then the GFR was estimated with this formula called the MDRD formula, just so that you know there was a formula used. Pretty accurate, also not so accurate when the kidney function is near normal. The one that's being used most now is the CKD epi for epidemiology, and if you look at your lab slips, you'll see that that is the method that's being used in the vast majority, about 90% of patients right now. But there are some newer things around now, and for example, say you come to see your doctor and the creatinine comes at say 1.2 or so, which could be a little high, could be normal, depending on the muscle mass and so on. There is this new test called the cystatin C, which is a very, very good test. It's cheaply done, and it's more accurate than the creatinine at this level of kidney function. So it's a useful test to know about. More and more of us are using this when you have borderline normal or abnormal values. And we can plug the cystatin C into the same formula, the CKD formula, and you can get a combination of creatinine and cystatin C, and that is a very, very accurate measurement. So the creatinine clearance, which you say some of you have already had, the problem is that you do need a 24-hour urine collection. It's cumbersome, people spill, you have to keep it refrigerated, but it can be very useful. And I'm going to give you an example of how this test can clarify and bring to light what the true kidney function is like. This happens to be a 58-year-old female who went to see a doctor at a routine visit. Blood tests were drawn, And you'll see here the BUN, the blood urea nitrogen, and creatinine levels looked fairly normal. But the formula, at the time the MDRD formula, kicked in a GFR of 48. And this would look like this patient has stage 3. You'll see more about the staging later on. It would appear that this patient has stage 3 kidney disease. A repeat creatinine was 1.1, and again the GFR was below 60, so by definition stage 3. So, does she have significant kidney disease? Well, some of the other things we look at would be the blood pressure, which was perfectly normal. There was no protein or blood in the urine, and otherwise the patient was extremely healthy, took some medication for mild osteoporosis, and oops. Other than that, very healthy, fit female. So we did a creatinine clearance, and these were the results. And I'll take you through this briefly because it is quite interesting. So the volume of the 24-hour urine was just about 3.8 liters. Got a trigger happy finger here. The serum creatinine was 1.0. And just that you know, the creatinine in the urine came out to 1.4 milligrams per 24 hours, and the weight was 56 kilos. And these all go into the formula for the creatinine clearance. So look what happened. On the measurement of the creatinine clearance, it came in at a perfectly normal level of 110. So this went a long way to reassure the patient that her kidney function was perfectly normal. That was very nice because this happened to be my wife. And so, as I said, we can use the cystatinus feed to help figure this out. So here's a screening test that came out some years ago that you could score yourself and see what your risk factors would be like, and if you fell into any one of these groups here, all you needed was 4 points, and you had a 1 in 5 chance of getting kidney disease later in life. The thing that bothered me a little bit about this is if you get to 60 or 65, your risks are automatically fairly high. And I'll talk a little bit more about this age thing in terms of the new guidelines for when we use cholesterol-lowering medications, but that come a little later. So there you go, that was released some years ago. I don't often use this, but it's out there. So this is the important slide, and this is the National Kidney Foundation classification of chronic kidney disease and the various stages. So let's go through this. So we have the staging, the GFR in mLs per minute, and more or less what kind of action plan is taken at this level. Well, stage 1, when the GFR is 90, I'm going to see patients with this. So this would be an example of a patient, say, who has protein in the urine, and that's about it. You just try and slow down whatever's going on. Stage 2 is when the GFR is between 60 and 89, and you try and get an estimation of what progression is going to be. You're in business when you get to stage 3, when the GFR is between 30 and 59. And here's where we start to see some of the complications like anemia and very, very early stages of bone disease. And this is where we want to start treating complications, maybe get some phosphate restriction going for the bones and so on, maybe some vitamin D. We get to so this would be moderate, this would be severe when you're in stage 4, when it's 15 to 29, and this is when we start thinking about the various options and choices and preparations for the various treatments such as dialysis and or transplantation. Stage 5, when the GFR is less than 15, that would be the time when you start scratching your head about dialysis. I'm going to say a lot more about this a little later, when the right time is to start dialysis, because there have been some major changes along with the thinking along these lines. So first things first, get to know your nephrologist. Try and build a relationship with your nephrologist and your primary care physician. It's important to know the number, know what these numbers mean, and particularly what the trajectory looks like it is in terms of the rate of progression. It's important to have some understanding of the various diagnostic tests, so when we sit down and talk about PTH, you know what PTH means, you know what GFR means. So the more questions you ask, the more empowered you will get, and the more knowledge you will get. We try and modify risk factors, which we'll talk about a little more, and to slow progression. And then, of course, monitoring of blood pressure and treating of high blood pressure. Home blood pressure monitoring becomes very important, and I'll talk some more about what are the current guidelines about what your blood pressure should actually be. So what are the modifier risk factors that we have in terms of patients with chronic kidney disease? First of all, high blood pressure. Second of all, you've got to treat the underlying disease if there is a disease that needs treatment. For example, lupus, systemic lupus, treating diabetes, and so on. These two drugs here, the ACE inhibitors and the angiotensin receptor blockers, anybody here not know what these drugs are? Okay, these are drugs that we use primarily for high blood pressure, but they have a particularly useful role in patients with chronic kidney disease because by virtue of the fact that they modify the little pressure in those little filters, they can actually slow down the progression of the kidney disease. So ACE inhibitors or angiotensin receptor blockers. Some people will get a little cough on ACE inhibitors, about 10 or 15% of patients, so we generally will switch them to angiotensin receptor blockers. I'll talk more about these in a little while. Diabetes control. We have been trying to get patients to get their diabetes under perfect control, which would be a hemoglobin A1C somewhere between 6 and 7%. It's becoming more evident that in the extreme elderly patients and patients with very advanced chronic kidney disease, strict control becomes a little less important because of the risks of hypoglycemia. So we have slightly more relaxed requirements for the A1C. If there's protein in the urine, we try and take measures to slow down the protein that's leaking, predominantly with one or other of these two agents. Salt restriction in the diet can slow down, reduce the protein leak. Anemia is an important part, and we have to sometimes use iron supplements, both oral and intravenous, and the various forms of EPO. We know that cigarette smoking is a risk factor for more rapid progression, so we encourage patients to stop smoking. Avoid anti-inflammatory agents like Advil, ibuprofen, which can have a bad effect on the kidney function. Although I must admit that I have had patients, quite a few patients with chronic kidney disease who have such a benefit in the terms of their quality of life by taking an anti-inflammatory once in a while. And as long as you give them a break from these drugs every 4 or 5 days, they tend to tolerate them reasonably well. The textbooks, however, say no NSAIDs. So sodium phosphate comes in fleets. It used to be that if you had a colonoscopy, you would prep with sodium phosphate solution. That is absolutely contraindicated in any patient with chronic kidney disease because the phosphorus gets rapidly absorbed into the blood and can seriously damage the kidneys. Virtually no one uses this anymore. Fleet's phosphor soda solution, a good source of a lawsuit in many instances, and I've seen patients who've been through this where they've ended up on dialysis after a big bowel prep for colonoscopy. Gadolinium is another substance that is used in MRIs, the dye in MRIs, and that we try and avoid in any patient with chronic kidney disease. Obesity is also thought to be a risk factor. Very, very large amounts of adipose tissue are actually biochemically active and release all kinds of inflammatory substances which can cause kidney disease. Let's talk a little bit about diet. I'm sure that most of you are aware that diet plays a very important role in the management of patients with chronic kidney disease as well as patients on dialysis. But if you look at it in a little more detail, the most important components, well, who thinks that significant protein restriction is absolutely important in patients with chronic kidney disease? That you have to restrict your protein intake. Okay. So this is a very controversial subject, and people have looked at the results of various studies in the role of protein restriction, and it's actually quite difficult to show that significant protein restriction plays a very important role in slowing down progression. It appears that whatever benefit that is achieved by rigid protein restriction is very short-lived, and that it may only manifest with a reduction in the protein leak in the urine. But if you look at different groups on a low protein diet or a normal protein diet or a higher protein diet over the long haul, it actually doesn't make all that much difference. So what we generally encourage is a decent amount of protein in the diet, such as about 1 gram of protein per kilogram body weight. So if you're, say, 160 pounds, that's 70 grams, 60 to 70 grams a day. What we do think is important, though, is to use fish, chicken, or vegetable protein as your main source of protein rather than red meat. In addition, it's also apparent that severe protein restriction can actually be harmful to you. And we've seen patients who present with end-stage renal disease who've been on very, very low protein diets, not properly monitored with supplementation, who actually come in with severe protein wasting, malnutrition, and they have very much worse outcomes. Another important role of protein is in the management of diabetes. So if you're going to put a diabetic, for example, who's overweight, trying to lose weight to control their diabetes, what do? We restrict their carbohydrates, we restrict the saturated fats, and what does that leave? So if you put these folks on protein restriction as well, they're going to switch to carbohydrates. So it's far more important to let the patients eat a little more protein to help the obesity, to help the diabetes. Salt. Salt is very important as well. But salt is a two-edged sword as well. And the recommendation has been in this country to have people with high blood pressure and chronic kidney disease limit their protein intake to 1,500 milligrams a day. Their sodium intake to 1,500 milligrams a day. The recommendation for the general population is 2,300 milligrams a day of sodium. Now what is milligrams? What does it translate to? Well, to translate to salt, you multiply by 2.5. So for example, if you're 2,300 milligrams sodium, it's about 5.5 grams of salt. If you want to translate sodium to teaspoons, yes? You multiply by 2,000. So, sorry, divide by 2,000. So 2,300 milligrams is just over a teaspoon of salt. Not a whole lot. And that's your daily. But salt restriction is important as well because patients with chronic kidney disease tend to have be much more salt sensitive in terms of their elevated blood pressure readings. So in patients on dialysis, in patients with chronic kidney disease, additional or excessive salt is important in terms of making the fluid overload worse, the blood pressure worse, and it actually promotes more protein leaking out through the urine. So the more salt that's coming out of the urine, because you're eating more salt, the more protein will be leaking. Finally, phosphorus is probably just as important. We try and have patients what we call proportional reduction in phosphorus. So as your kidney function declines, you should eat less and less phosphorus. And there are plenty of handouts over here, but mainly nuts, beans, and dairy products. We should start reducing those fairly early on because the body reacts to excess of phosphorus by making more parathyroid hormone and causing bone disease. Lipids. We'll talk more about lipids in a little while. Family history. There's not a whole lot you can do about your family history. Exercise definitely benefits patients with chronic kidney disease, helps blood pressure, improves mood, and keeps the weight down as well. Patients feel better about that. I'm not going to say anything about HIV and hepatitis B and C. So we're going to go ahead and talk a little bit about some of the complications of chronic kidney disease. Time is moving along here, but we'll move along here. So as I mentioned before, we treat anemia in chronic kidney disease, and we monitor depending on the stage of the kidney disease, we will monitor the blood count, the hemoglobin count at regular intervals, ranging from once a year to once every 3 months. We like to, if we have to treat this with these agents, we don't correct it to normal levels because of the risks of blood clots, etc. We often have to use supplemental iron, and then we use these red cell stimulating agents, Aranesp, Procrit, Epigen. I'm sure that many of you have heard of these agents. Expensive drug. We have to get prior authorization for using this, but the good news is that if you're on Medicare, it is one of the approved drugs that are paid for by Medicare and your supplemental plan if you have this anemia of chronic kidney disease and at least stage 3 kidney disease. There's a black box warning put out by the FDA. And the black box warning says that the only indication for using these agents is the need to prevent need for a blood transfusion. That's the only approved FDA indication. And we have to be very careful with these drugs if there have been previous blood clots, strokes, heart attacks. And as I mentioned, we do not let the hemoglobin go up to very high levels. Usually we stop at I usually stop giving it for a while when the hemoglobin hits 11.0, which is still anemic by many people's standards. But it does improve quality of life. Now, high blood pressure. I don't know if, do anybody who here have heard about the new guidelines for blood pressure control in the general population? Okay. So it used to be that the guidelines would be in the general population, blood pressure is less than 140/80. Patients with diabetes and kidney disease less than 130/80. Patients with protein in the urine less than 125/75. This has all been changed by the recent JNC8 guidelines, which have come out. And basically the target now, based on various outcome study, good research, that you don't get any more bang for your buck. If your blood pressure, if you've got it less than 140/90 on medication, you're doing fine. That doesn't mean to say that if your blood pressure is 120/80 on medication that you should stop your medication. It doesn't mean that at all. If you're over the age of 60, they'll allow you to have 150/90. If you're over the age of 80, we don't know. We have no idea what optimal blood pressure is over the age of 80. We do know that very low blood pressure in patients on dialysis, in the extreme elderly, very low blood pressure is associated with a worse outcome, so-called J curve. The commonest drug that we like to use would be the ACE inhibitor or the angiotensin receptor blocker. We used to use combination therapy of these two drugs, but we don't do that anymore because of bad outcomes. And we do know that they can slow down. First of all, if you control your blood pressure, you will slow down the course of kidney disease. If you have protein in the urine, you'll do even better with ACE inhibitors and angiotensin receptor blockers. But they also reduce the risk of heart attack, stroke, and reduce the risk of an enlarged heart. It's very rare that we can control blood pressure with one drug alone. Maybe initially, but sooner or later, 2, 3 drugs combinations should be definitely used. High blood pressure in the African American population is a very different condition. It's associated with a much higher incidence of chronic kidney disease. And the data show that they do not do as well with blood pressure lowering in terms of preventing kidney disease. We like to encourage patients to get a monitor. Home blood pressure monitoring is important. And there are various frequencies at which you should monitor your blood pressure.
What are they?
Sorry?
What are the frequencies?
The frequencies of measuring depends. It depends on what the stage is. If you're just starting off medication, probably 3 times a week. Once you're stable, once or twice a week, but any change in dosing or frequency of medications, back to 3 times a week. Some people even do it daily, but I don't encourage that. It becomes very cumbersome. Cardiac disease. Well, one of the problems with patients with chronic kidney disease is that there is a higher incidence of cardiovascular disease. And so chronic kidney disease and even protein in the urine is a marker or a risk factor. And they're the usual risk factors that we know about cardiac disease: high blood pressure, high cholesterol. But there's probably some other factors as well, non-traditional factors like with antioxidants and inflammatory molecules and so on. And one of the reasons why many patients with chronic kidney disease don't need dialysis or ever need dialysis is that they have cardiac disease which intervenes. So it's very, very important to prevent cardiac problems, and in addition, they also get calcification of blood vessels in the muscular part, the inner part of the blood vessel, as opposed to atherosclerosis, which is in the lining of the blood vessel. And this can affect many vessels, especially in diabetics. The 5th complication is bone disease, and this can start very early on with the vitamin D story, where vitamin D becomes lacking, and then the parathyroid glands up in the neck become more active and produce more PTH. There is an increased risk of fractures, and we spoke about reducing the phosphorus intake. And we use various vitamin D substances to prevent the parathyroid hormone from going up, and we try and keep the calcium and phosphorus levels low with phosphate lowering the diet, and sometimes phosphate binders, which are drugs used to bind the phosphorus in the diet, And in patients on dialysis, there's a drug called Sensipar, which some of you are familiar with. Lipid abnormalities. Well, this is very controversial. But right now, in terms of patients with chronic kidney disease, the recommendation is that every patient over the age of 50 should be on a statin. This is recommended by KDIGO, which is the International Organization Kidney Disease Improved Global Outcomes. And this is the recommendation. Usually it's a statin, like atorvastatin or pravastatin. And the interesting recommendation is that you measure the lipids, the cholesterol, HDL, LDL once, put them on medication and forget about it. There's no goal, there's no definite goal for LDL lowering. It's the mantra is fire and forget. As I mentioned, no definite target. Now what if you're 18 to 49? Well, and you have chronic kidney disease, the recommendation is treat if diabetic, if there's a previous history of coronary artery disease, if there's a previous history of stroke. And we now have that calculator which you can put on your smartphone where you can calculate your 10-year risk. I've got one on my smartphone if you want to use it, it's quite simple. And you plug in various variables, your blood pressure, whether you're diabetic or non-diabetic and so on, and it gives you a 10-year risk. And if in this country, if it's greater than 7.5%, the recommendation is to go on statins. It's quite interesting that in the United Kingdom, the 10-year, the guideline is 20%. So if you just play around with this little app and you say 65, it's extremely unlikely you are going to get away without being recommended to go on a statin. So it's a strange thing, and not everybody agrees with it. So patients with chronic kidney disease and transplant patients, this applies to. The problem is in dialysis patients. There have been very large studies that show that there's absolutely no benefit from statins if you're a dialysis patient. So generally what we do is if a patient comes to us starts dialysis and they're already on a statin, like Lipitor, we leave them alone, we leave them on it. But if the cholesterol comes in at 240 or the LDL goes up, there's really no evidence that putting a statin on board will help things. And there are some risks with statins. I'm sure some of you have read the news recently about some of the risks of acute kidney injury. That's pretty much been debunked, but the one risk is that there is a higher risk of diabetes. Anybody know why there's a higher risk of diabetes, patients starting on statins? Because you get a false sense of security that you can eat anything, and you gain weight, and more people become diabetic.
Could you talk a little bit more about the statins? I'm not sure. Are those for regulating blood pressure?
No, statins are for regulating cholesterol, for lipid abnormalities, either a low HDL, a high LDL, and a total cholesterol. Some of the other depressions, these are very, very important, but depression is very common. And that's why we need good screening methods. We have medications available, psychotherapy, group therapy, and it's very, very important to avoid isolation. Very briefly, male and female sexual dysfunction is much more common in the general population. Well, not much more, a little more common than in the general population. It's actually very common in the general population as well. If you look at patients, males over the age of 40 have a 40% incidence of erectile dysfunction, if you know that. So a little higher. Unfortunately, it tends to be a taboo subject. People don't like to talk about it. Generally, nephrologists don't bring it up very often. Patients don't like to bring it up very often. It's kind of felt, well, let's not go there. Unfortunately, it can affect males and females. And there are many reasons. There is a disturbance in the hormonal levels from the pituitary to the gonads, the ovaries, the testes. But there's also high blood pressure, there's diabetes, and there's medications which can all contribute to this. And these would include loss of libido, various pain syndromes, erectile dysfunction, menstrual changes, and reduced fertility. And I'm not saying infertility. We've seen patients on dialysis become pregnant and have babies on dialysis, becoming more and more common. The important thing to know is that treatment is available for these various problems. Diabetes, very important. It used to be that we never saw kids with type 2 diabetes. They were all insulin dependent, juvenile, so-called juvenile onset, type 1 insulin needing, type 2 adult onset. That's all gone now. By far the commonest type of diabetes that we're seeing in kids today is type 2. And this is generating an epidemic of obesity, hypertension, and it's going to become a much more serious health and economic problem in this country and worldwide as well. The problems associated with diabetes would be microvascular, small blood vessels, the retina, the nerves, the kidney, and then macro, meaning large blood vessels, heart, and strokes. So again, I spoke to you a little bit about protein in the diet. I'm not going to repeat this now because we've already spoken about this. We spoke about salt, phosphorus, and use of a dietitian to help you along the way is very important. Yes, sir?
Sea salt or iodine salt, are there differences between?
I don't believe so.
Salt and salt.
Salt is salt. Kosher salt is good as well. How often should you be seeing your doctor? It depends on the stage. Stage 3, once a year maybe. Stage 4, once every 3 to 6 months. Stage 5, once every 1 to 3 months. Important counseling, nutritional. An important thing also is the options training. And it's very important to get this discussion going fairly early along about the various options. Lab monitoring, again, depending on the stage. Managing iron and depression. I'm going to skip that slide. Now, preparation for renal replacement therapy. It's very important to have options education, and many of you have been to classes, have gone through CDs, read various papers on this. We like to do this with a shared decision making, that is the patient, if the patient is competent, the family, the doctor, and after repeated visits as well. And it's very important to have a life plan and do this in an advanced pattern. We don't want to have to deal with putting a catheter in the neck in the emergency room because the patient has avoided or not wanted to, or the doctor hasn't discussed what type of dialysis, if they want dialysis. Some important things for you to know: vascular access is the placement of a fistula or a graft in the arm. We usually do this in stage 4. More recently, it appears that the best time to do it is just when the GFR is less than 15. If you do it earlier and with a very, very slow trajectory, we can be sitting with a fistula in the arm for 2 or 3 years, and that's probably not a great idea. The mantra is fistula first, which is the very, very minor surgical procedure where the artery and the vein are joined together. It takes about 3 months to mature. And catheter last. The catheter is the large catheter that comes out of the side of the neck and can be a great source of infection. We like to use the non-dominant arm. Before we do it, the patient needs mapping where they look at the veins with a sonogram and find the best vein, and again the timing is the best thing. Home therapy, briefly, may be the best option for some patients, not for everybody. I think home therapy is underrepresented in our patient population. for various reasons. We know that in this country it's underutilized compared to Canada and the United Kingdom. People on home therapy often feel a lot better, but as I said, it's not for everybody. There are patients who've been through both forms of therapy. There tends to be a physician bias towards one or the other, and that's probably not the best thing. But we do like to know the options and make a decision before advanced stage of stage 5. Now, this is important. When is the right time? It used to be that we used to start patients on dialysis when the GFR was about 10, but if you're diabetic, 15. That has been shown in various studies to be less advantageous to starting patients much later. The people looked at outcomes in various meta-analyses, and they found that patients who started dialysis earlier actually did a lot worse than patients who started later. This would be counterintuitive because you would think that the sooner you start dialysis, the better, but that's not the case. And so we also know that the first 3 to 6 months of dialysis can be a little riskier than once you pass that stage. We know that in older patients that the slope or the progression of kidney disease can be a lot slower than in younger patients. So older patients are often best left alone for as long as possible, and they can have a better, or at least an equal quality of life off dialysis. The Canadians have just come up with guidelines where they are now recommending 5 as the number to start. This was unheard of a decade ago. So 5 or 6, close monitoring for symptoms, uremic symptoms, and these are some of the symptoms, very briefly: loss of appetite, nausea, vomiting, itching, hiccups, restless legs, and so on. We generally don't let symptoms get to an advanced stage. We start dialysis before the patient becomes very ill. Is it for everybody? It's very personal. It's important to have the shared decision process. We like to have an advance directive from the patients to say what they would, and also to tell their family members what their wishes would be. We know that there are certain conditions there where there would be no benefit from putting yourself through dialysis, like a persistent vegetative state. I'm sure you've read some of these cases in the news recently. Terminal malignancy, or if it's just not technically possible. And we know now that medical management without dialysis in some patients may provide better quality of life and a similar life expectancy. Transplantation, we try and list you when the GFR is less than 20. This is the UNOS guidelines where you can go on the waiting list. When you don't need a transplant at that level, but you cannot go on the list if the kidney function is better than that. There are some new qualifications that are coming in, but various kinds of kidneys would be a living related or non-related transplant, a husband, a wife, a friend, an employer, a boss. I've seen all of that. The waiting list for deceased donors is extraordinarily long in this area, 5 to 7 years. Although if you're an older potential recipient, there is this program where you will take a slightly less quality kidney, and that's much shorter. I'm sure some of you have read about the donor swap programs. If you have a donor that's not compatible, there's the ABO for blood group is not incompatible. There's a program for getting rid of the antibodies, nearly at the end. And transplantation is the preferred form of therapy, and in deference to Linda, I would say that it provides the closest to a cure. It's not actually a cure, but it's the closest to a cure. Support systems, well, family, friends, caregivers, those immediate to you would be the best initial caregivers. As you've heard today, there's this wonderful organization called the Bay Area Association of Kidney Patients. That's their email address or their website. Get involved with this. There are various forms of sources for psychological counseling, social workers. Google is a wonderful resource for any question that you may have. A nephrologist, primary care physician as well. So, in conclusion, chronic kidney disease is a long-standing condition that is best treated by a capable and caring team with a well-informed and educated patient and advocate. Most patients can live and able to live a long, healthy, and normal lifespan. And it's very important to be fully informed at all stages, develop a life plan, and stay one step ahead. And that's all I have to say. Thank you very much.